Bone and joint infection. Key points. Osteomyelitis and septic arthritis should be suspected in any child presenting with fever, pain, and limited use of the affected limb or joint. Urgent surgical intervention reduces the risk of serious complications in septic arthritis, but should not delay antibiotics. Always consider alternate diagnoses such as trauma, non-accidental injury, inflammatory conditions, and malignancy. Background. Septic arthritis is the intra-articular infection of a synovial joint. It may coexist with osteomyelitis, an infection localized to the bone. Most cases are spread to the bone or joint via the bloodstream. Infection may be introduced via a penetrating injury. Staphylococcus aureus is the commonest cause, though other organisms should be considered based on age. Group B. Streptococci. In neonates. Kingella kingi. In 6 months to 4 years, immunization status. Haemophilus influenza. And underlying illness, e.g. Salmonella. In children with sickle cell disease. Discitis is inflammation/infection of an intervertebral disc, typically occurring in preschool-aged children and most often affecting the lumbar spine. Diagnosis requires a high index of suspicion. Assessment. History. Site of pain. Septic arthritis, most commonly hip or knee but could be any synovial joint. Osteomyelitis, most commonly femur or tibia, pelvis, and humerus but can be any bone. Onset and duration of symptoms e.g. acute, and LT 2 weeks, or chronic. Fever may not be present, particularly in infants. History of trauma or fall symptoms may be incorrectly attributed to minor injury. Functional limitations e.g. limited range of motion, refusal to weight bear or non-use of the affected limb or joint. Irritability in infants e.g. when picked up or nappy changed. Risk factors for development of a severe or disseminated infection include immunocompromised child, neonate, delayed presentation, delayed diagnosis. Examination, fever and signs of blank. Bone and joint examination using look, feel, and move. Look. For resting limb position, e.g. hip flexed, abducted, and externally rotated, swelling and erythema, open wounds, or soft tissue infection, potential source. Feel. For tenderness, warmth, and effusion in all major joints. Move. Passively, in all planes of motion, in all joints above and below the site of pain. Actively, by asking child to move or by placing an object out of reach. Compare with contralateral side. Don't forget the spine. Assess gait and general posture. Reluctance to weight bear or to use the affected limb. Differential diagnoses. Transient synovitis. Trauma, including non-accidental injury. Inflammatory conditions e.g. inflammatory arthropathy, chronic recurrent multifocal osteomyelitis, acute rheumatic fever. Pyogenic myositis. Discitis. Malignancy, including leukemia. Key clinical features of most common differentials. Fever, osteomyelitis, may be absent. Septic arthritis. Osteomyelitis. Fever, may be absent. Onset. Subacute onset of limp, non-weight bearing or refusal to use limb. Features. Localized. Limb pain, may be poorly localized. Systemic. Features. With or without systemic illness. Septic arthritis. Fever, usually present. Onset. Acute onset of limp, non-weight bearing, or refusal to use limb. Features. Localized. Hot, swollen, painful, joint. Systemic. Features. Systemic symptoms, usually more severe. Pyogenic myositis. Fever, usually present. Onset. Subacute onset. Involve limp. Localized. Features. Pain usually well localized. May have abdominal pain, psoas involvement. Systemic features. Systemic symptoms, usually more severe. Discitis. Fever, typically absent or low. Grade. Onset. Subacute onset of irritability and back pain. May involve limp, or refusal to crawl or walk. Localized. Features. May show refusal to bend forward, loss of lumbar lordosis, percussion tenderness, overspine, hip pain, lower limb neurology, ileus, higher lesions. Systemic features. Irritable, with or without systemic illness. Transient synovitis. Fever, typically absent. Grade. Onset. Subacute or acute. Onset of limp. Recent. Recovery from viral illness. Localized. Features. Weight-bearing, limp. Systemic features. Systemically well. Recent viral symptoms. Management. Blank. Investigations. Investigations may not be necessary for a child who is systemically well, afebrile, and is walking or using the affected limb without significant discomfort. A clear working diagnosis and early follow-up is usually sufficient. Any child with systemic illness, significant bone or joint pain and limitation of movement requires urgent investigation and discussion with an orthopedic team. Pathology. No laboratory test, or combination thereof, is specific for a diagnosis of bone or joint infection. FBE, ESR, CRP. Inflammatory markers may be normal, especially early, in chronic infection, or for infection of the small bones, e.g. hand, feet. They may also be used to monitor effectiveness of treatment. A blood film may help to rule out other causes such as malignancy. Blood cultures. Taken prior to antibiotics if possible. Synovial fluid aspiration. Where appropriate, in cases of suspected septic arthritis. In consultation with an orthopedic unit. Should not delay antibiotic treatment. Imaging. X-ray. May exclude other causes of pain, e.g. fracture, tumor, often normal, until 7 to 10 days in osteomyelitis. Consider ultrasound to identify joint effusion in suspected septic arthritis. Highly sensitive, but not specific. MRI with contrast. Preferred test for osteomyelitis, especially where symptoms localized. May demonstrate subperiosteal abscess or marrow involvement. Highly sensitive for myositis. Technetium bone scan. May be useful where access to MRI is limited. A positive bone scan is not a specific finding. A negative bone scan cannot rule out infection or other serious pathology. May help to identify a multifocal process or infection in ill-defined locations. CT scan plays a limited role in suspected bone and joint infections. Should not be used in lieu of MRI or bone scan. Treatment. Septic arthritis requires urgent aspiration /arthrotomy and washout. Do not delay antibiotics. Antibiotic treatment. Blank. In uncomplicated cases of both osteomyelitis and septic arthritis, commence. Flucloxacillin 50 mg per kilogram, max 2g, intravenous every 6 hours. Or, for children under 4 years, higher risk. King Elakingi. Consider as a single agent. Cefazolin 50 mg per kilogram, max 2g, intravenous every 8 hours. Criteria for switch to oral antibiotic. In a child with uncomplicated infection who shows clinical improvement, remains afebrile and has improving inflammatory markers, a switch to oral antibiotics may be considered after 2 to 3 days of treatment. Consider oral cephalexin 45 mg per kilogram, max 1.5 g, oral, every 8 hours. Uncomplicated cases of osteomyelitis usually require total treatment duration of 3 to 4 weeks. Septic arthritis usually requires 2 to 3 weeks. Unusual sites of infection, e.g. small bones of the hands and feet, vertebra, disc, flat bone infection, e.g. sternum, skull, scapula, or unusual or resistant organisms will likely need longer intravenous and total duration of antibiotic therapy. Discuss with infectious diseases team. Consider consultation with local pediatric team when children with suspected osteomyelitis/septic arthritis should be discussed with an orthopedic team, in conjunction with general pediatrics. Consider infectious diseases consultation in the following circumstances: failure to respond to treatment, either clinically or biochemically, resistant or unusual organism, chronic infection, and GT 2 weeks, disseminated infection or unusual site, age and LT 3 months, immunocompromised. Consider transfer when child requires care above the level of comfort of the local hospital. Consider discharge when child tolerating appropriate oral antibiotics or has planned outpatient for therapy, e.g. hospital in the home, afebrile, well child. Improved inflammatory markers and clinical indicators. Weight-bearing/using involved limb. The family has been advised to return to emergency in the presence of fever or a deterioration in symptoms. Additional notes. Potential causative organisms. Organism: Staphylococcus aureus. Higher risk group/settings. All ages. Consider risk of MRSA. King-Ella kingi. Infants and preschoolers. Group B streptococci. Neonates, Staphylococcus aureus. Still most common. Group A streptococci. Older infants and children. Streptococcus pneumoniae. Immunocompromised, Escherichia coli. Neonates. Salmonella. Children with sickle cell disease. Pseudomonas aeruginosa. Penetrating foot injury. Neisseria gonorrhoeae. Sexually active adolescents.